On the fourth day of Christmas, my ER gave to me 4 pressors running, a triple lumen cath, 2 trauma shears, and a CHF exacerbation. Let's talk about the 4 most common vasopressors used in our critically ill patients. The most common one we reach for, and it's our first line pressor in a lot of types of shock, specifically distributive shock, is norepinephrine. Norepinephrine raises blood pressure by acting on alpha 1 receptors to increase the SVR, meaning that it cinches up the vasculature and it shrinks the tank. But norepinephrine also acts on our beta 1 receptors, which acts to increase contractility and the heart rate with which our heart beats. Now, it's important to differentiate. Norepinephrine acts more on the alpha and less on the beta, which is opposite of epi when we get to that in a minute. My second favorite vasopressor, and oftentimes the second one we reach for if the norepinephrine isn't doing the trick, is vasopressin, which is just an exogenous or a synthetic version of ADH, which is something that our body uses in order to regulate our own blood pressure. And vasopressor also acts in 2 different ways. Number one, it acts on those V1 receptors, and it has very potent vasoconstrictive capabilities to it. Additionally, it acts on the V2 receptors, which are there in the kidney, and it tells the kidneys to increase water resorption. So normally our kidneys work by filtering out blood and squeegeeing plasma out that then becomes urine. But when we use this vasopressin, it tells those V2 receptors, hey, don't squeegee out so much water, hold it in, and we want you to increase the intravascular volume. So it also shrinks the tank, but it also helps to fill a tank. And vasopressin tends to work a little bit better on our patients who are not responding to catecholamines. So if you've maxed out your norepinephrine, vasopressin can be a very good second choice. And third up, epinephrine. It's very chemically similar to norepinephrine and also acts similarly. Yes, it acts on those alpha 1 receptors to cause vasoconstriction, but it also acts on those beta 1 receptors in the heart to improve contractility and increase the heart rate. Now with this one, it's the opposite of norepinephrine. Remember we said that norepi acts more on the alpha and not quite as much on the beta? With epi, it's the opposite. It acts more on the beta receptors and less on the alpha, which we know also in turn then increases the oxygen demand on the myocardium. So epinephrine might not always be the best choice for your patient, especially if they've got something going on in their heart, because this is just going to increase the rate of that hungry hippo action that the heart has going on. And then our fourth pressor is, of course, the Lord whose birthday we are celebrating this month. Oftentimes, Jesus, good vibes, if that's what you believe in, is what we need to help our patients. But also some other Hail Mary options might be using something like a cyano kit, which I recently learned is used in our patients with vasoplegia that's caused by nitric oxide. So it goes in and it binds up that nitric oxide that has that very powerful vasodilatory effect. You can also use methylene blue, which is going to prevent the synthesis of nitric oxide in our patients. But just note, your fourth pressor is oftentimes a Hail Mary. And if we're not getting any results with those first 3, we definitely need to consult the fourth pressor.